Good morning, everyone. We're happy to see you all. We're going to get started. Welcome. This is the discipline group session, Nuts and Bolts for CF Genetic Counselors. My name is Renee Temme. I'm a genetic counselor, and I'll be co-moderating this session with Charlotte Close. We are excited. We have a great lineup of wonderful speakers this morning. After each speaker, there will be about 5 minutes for questions. You can ask questions through the app or up at the microphone here in the middle. So just an overview. Given the recent guidance from the CF Foundation to include genetic counselors on CF core care teams, our session will focus on both practical and timely genetic counseling issues when it comes to CF. Speakers in the session will discuss genetic counseling for CF across the lifespan, strategies to integrate genetic counselors into the CF care team, and strategies to integrate genetic counselors into the CF care team, and how to apply psychosocial skills in the setting of targeted therapeutics. Oops. Okay. I'm pleased to formally introduce Charlotte. Charlotte is a pediatric genetic counselor at Columbia University Irving Medical Center. She works to expand access to CF genetic counseling through clinical innovation, research, and education. Her studies focus on reproductive health counseling for adolescents with CF and improving statewide newborn screening follow-up. She co-authored the CF Foundation position paper, Redefining the Cystic Fibrosis Care Team, teaches and mentors in Columbia's GC graduate program, and advocates for licensure and equitable access to genetic counseling nationwide. All right.
Take it from here. Okay, I'm equally happy to introduce Renee. So Renee is a pediatric genetic counselor at the Children's Minnesota Genetics Division, working with the genetics, CF, and PCD programs. She provides genetic counseling for infants and families following positive newborn screening for CF, and is an integrated care team member of the multidisciplinary CF team. She's led QI projects and grant-funded projects to expand access to genetic services through telegenetics and newborn screening education, and her research has advanced the understanding of CFTR-related metabolic syndrome. Renee is also a clinical supervisor for genetic counseling students in Minnesota. Okay, so now that you know us, we'll move on to our learning objectives for the talk. First, we're going to start out by describing the unique genetic counseling needs of people with CF at key developmental stages, informed by some of our speakers' real-world clinical experience and the evolving standards of care. Next, we'll examine strategies used to integrate genetic counselors into CF care teams practically by reviewing genetic counselor experiences with multiple models of care delivery. And then we'll wrap it up by discussing how GCs and CF centers are increasingly taking on roles reviewing targeted therapeutics in clinical care and how GC psychosocial skills can be of benefit. Before we do that, we have to give the broad disclaimer for all of our speakers in this session that we're not speaking and representing the views of the CF Foundation. Before we dive into our talk content, we do want to give a brief update from the Education Committee, and that'll be given by our GC colleague, Kimberly Foyle.
Thanks so much, Charlotte. Good to see everyone this morning. As Charlotte mentioned, I am Kim Foyle, genetic counselor from the Medical University of South Carolina. And for the last 3 years, I have served as the inaugural genetic counselor on the CF Foundation's Education Committee, which has been a really great experience. I'm happy to be passing the baton to Angelique Mercer for the next 3-year period. And the Education Committee likes to bring a brief update to each of the disciplines about who we are and what we do so that you can keep it in mind as it may benefit your practice and your patients. So the CFF Education Committee is a group of adult and pediatric multidisciplinary specialists, and there are also adults with CF and parents of kids with CF to represent the community perspectives. Each individual serves a 3-year term on the committee, and people are selected following an application process. The application asks individuals to explain experience with CF, experience creating and reviewing educational materials, and elaborate on their own ideas and vision for the development of materials in CF education, such as what is needed and how that may be accomplished. Applications are shared in the spring of each year, and there are a different number of seats available for each discipline. Right now, there's just one genetic counselor role. Some of the larger disciplines may have, say, 2 spots. So we won't see another genetic counselor application cycle open for a couple more years unless they expand the number of genetic counselor spots. But the open positions are shared each spring via the listservs and community voice. And this is a list of the current members and the new members who are joining this fall as some of us roll off. This is a picture of the partial group from last year's NACFC conference. So the group typically meets quarterly on a virtual meeting and then has an in-person meeting at NACFC that has a concurrent virtual option for those who may not be in attendance. It's a great group and been exciting to work on educational materials that are timely and relevant and applicable to all CF centers. In the last year, we have developed and approved materials that have a lot of relevance to genetic counselors and the patients that we serve. There's a new introduction to CF book for patients and their families that's available in English currently, but a Spanish edition coming soon. And this one can be requested in hard copies if you want to hand them out in your center. There are also, of course, electronic copies. And we have a new birth control guide for people with CF that is already available in English and Spanish, and a family planning handout for men with CF. Other resources that have been developed in the last year are discussing CF liver ultrasound findings, a guide for CF clinicians, CF Rise updates, Bright Beginnings, Empowering Parents, which is some practical information and tips for parents with a child who's newly diagnosed with CF, a guide for developing health literacy friendly resources, and a CF education resources guide detailing the resources available. The resources that are aimed at community members are generally tried to be produced at about a 6th grade reading level with health literacy in mind. And then there are some resources that are geared to care team members, like the liver ultrasound discussion facilitator, and that has a slightly higher reading level because it's meant to be clinician facing. So all of these materials are available in the my.cff resource library. If you log into that platform, you can download any of the available materials. You can search by topic. You can order hard copy materials. And if you have trouble with any of that, you can contact the Education Committee at resources@cff.org. I'm going to show you a couple of screenshots of how to use the platform. So once you log into mycff.org, and you have to have your username and password and 2-factor authentication, you can search for resources in the resource library, which is above that farthest green arrow. But if you want to order hard copies, you click on order forms and start a new order form for whatever materials you would like to have shipped to you or your center. And you can select however many you want of the materials that are available in hard copy. And ways that you can get involved, even if you're not serving on the committee, there's a section for educational abstracts here at NACFC. So submitting abstracts in the educational category advances CF education. If you find that there are materials on the list that are out of date or no longer available, please let the Education Committee know. The Education Committee does annually divide and conquer on reviewing the materials to try to ensure that they're all accessible and up to date, but there are a lot of them, so we appreciate the help of the community. And of course, distributing CF education to the CF community. And if you have developed a resource or have an idea for a resource that you think should be created, please reach out. We love to hear ideas and are happy to review anything that you've created to give it the authentic stamp of the CF Foundation for distribution to all centers and patients. That's all I have. Happy to take questions. And thank you for giving me a few minutes.
Thank you, Kim. It's always great to hear from the CF Education Committee and all that you're working on, and thanks for sharing the new resources. I'm excited to introduce our next speaker, Sumeda Gate. Sumeda is a genetic counselor at St. Vincent Hospital in Green Bay, Wisconsin. She works in the Medical Genetics and Cystic Fibrosis Center there. Sumeda received her Bachelor of Science in Genetics at the University of Wisconsin-Madison and completed her Master of Science in Genetic Counseling from Sarah Lawrence College in New York. She has been a genetic counselor at St. Vincent Hospital in Green Bay since 1996. She joined the multidisciplinary team at the Hemophilia Outreach Center in 2011. Sumeda enjoys the opportunity to provide multi-specialty genetic counseling services to individuals in a wide variety of settings, including prenatal, cancer genetics, neurogenetics, cardiogenetics, and as a genetic counselor integrated into the CF Care Center for over 20 years. Her years of experience as a genetic counselor with expertise in genetic analysis and patient-centered care are beneficial when presented with the challenge of explaining complex genetic information in a way that is personally meaningful and empowering to the individual or family. While she enjoys all aspects of genetic counseling, working with families and staff in the CF Center is her passion. Welcome, Sumeda. Yeah. And then we were asking each speaker today what the best career advice that you've received has been.
The best career advice is lean on your genetic counselor, counseling people. They're amazing and will openly welcome you into the genetic counseling community. So if you don't already have a network of genetic counselors, start to develop one here. Thank you, Renee. And I have no relationships to disclose related to this presentation. And I'm bringing my phone here because there's just one part of this presentation where I kept tripping up my words, so I texted myself the words, so I might have to look at them. I might not trip them up this time, but so. My objective is to describe the unique genetic counseling needs of people with CF at key developmental stages informed by real-world clinical experience and evolving standards of care. And welcome to this very first session. Well, some of you have been here from yesterday, but for most of us of the NACFC, it's wonderful to see so many familiar faces and also many new faces. It's just amazing. Me, like a lot of us, often compare our insides to everybody's outsides, and believe me, your outsides look amazing. You are all such powerful and wonderful, productive genetic counselors. I often see and read about all of the things that you're doing, and I'm continually impressed. I'm honored to be part of this amazing group of people, and thank you so much for inviting me today. So genetic counselors have specialized training and expertise related to CF. We can help bridge our patients through many aspects of their lives. You might be a genetic counselor that is in a CF center. You might work regularly with adults who have cystic fibrosis and may be asking you questions about potential pregnancies, or maybe they are pregnant. Maybe they don't know what they might want to know about. How is this pregnancy going to be the same or different than other pregnancies? Do I need to see any specialists? What will the maternal fetal medicine doctors be telling me that might be different? What about carrier screening for other genetic conditions? For myself, what about carrier screening for my partner? And what about my newborn? Do we need to do anything special with that newborn, especially related to if there has been prenatal exposure to CFTR modulators. These are all things that you are very familiar with and may be dealing with often. Genetic counselors who are not necessarily embedded in the CF Center may also be very involved with carrier screening. You may be asked questions about carrier screening for either people who have CF and they want to pursue other carrier screening, or partners of people with CF or CFTRopathy. And when I say CFTRopathy, I'm talking about the non-formal description of conditions like CRMS, CF SPID, and CFTR-related disorders. So if you have a person who has CF and or a CFTRopathy, and their partner wants to do carrier testing for CF, now are you going to be offering to them information for releasing variants of varying clinical consequence? And this is a conversation that you might regularly have with your patients. So if you are a genetic counselor in the pediatric setting, or maybe in a CF center, you might be asked about newborn screening, and often those newborn babies that have a positive newborn screen might have a test that's positive for cystic fibrosis or a CFTRopathy. You may be one of the first people to explain some of these complex genotype-phenotype correlations. You might be one of the CF care team members that is going to talk to them about what is the likelihood of my baby transitioning to a CF diagnosis. If you are involved with your urology department or other adult conditions, they might be referring to you patients who have CBAVD or patients who have pancreatitis. So regardless of which specialty you're in, many of us are going to be dealing with questions related to CF and CFTRopathies. So this is a very relevant topic for today. So as many of you know, there have been published position papers regarding cystic fibrosis, and they have included the redefinition of the CF care team as one of the papers. And based on those position papers, because of the increasing complexities of CF care, they have determined, among the other important additions, to include a pharmacist and access to a genetic counselor as part of a CF care team. And this is hugely important and relevant, of course, to all of us. So another important publication in 2024 was the CF Foundation's evidence-based guidelines for the management of CRMS and CF SPID. And as part of that paper, it notes having access to a trained GC to discuss genetic findings and complement team members in providing psychosocial support promotes understanding and strengthens long-term retention of genetic knowledge. Genetic counseling at regular intervals throughout the lifespan allows for timely, accurate, supportive, and non-directive information on recurrence risk and reproductive options. These are two of a really important and growing body of evidence that indicate the importance of genetic counseling in our field. And just a huge congratulations to you for all of the people that have contributed and led the efforts related to these and many other papers. It's amazing the work that you've all done, and really a congratulations, because this was a long time coming. So way to go, everybody. So this is just a very basic example of something that you might see if you are working with your CF team. So you have a person that has cystic fibrosis. She's really happy to be thinking about pregnancy, or eventually she is pregnant, and she wants to know the things that we kind of talked about, like what about carrier screening for other conditions for me? What about carrier screening for my partner? And if you may know many of the answers to these questions, but you may not know all of the answers to these questions. So anytime we're looking toward doing testing that we're not super familiar with, as is my advice to lots of people, and I take this advice myself, that if we're not familiar with something, reach out to our fellow GCs. So we have lots of resources. We can reach out to our CF SIG, and if you haven't joined the CF SIG through the NSGC, please do so. And then also we can reach out to our prenatal GC genetic counselors. Most of the time, if anybody contacts me, I'm more than happy to reach out to them and go through anything that might be helpful to them. Some of the things that are helpful to people who are not typically talking about carrier screening would include just the basics, like you might not be the one who is going to facilitate that carrier screening, but just to have an idea of what to explain to your patients that might be of relevance. So which labs do you usually use? What panels are there? What does insurance typically cover? And not that you have to have the A to Z answers, but these are some things that at least you can start developing kind of a basis of knowledge about if you don't already have that, which many of you might. So as you probably know, there's carrier screening guidance from the ACMG and from ACOG, and I'm not going to read through all of this, but basically ACMG recommends universal, ethnicity-neutral carrier screening for all individuals considering pregnancy or who are pregnant, and they advocate for a tier-based panels. So tier 1 would be for cystic fibrosis, SMA, and other conditions recommended by ACOG, such as hemoglobinopathies. Then tier 2 to 4 expands to include additional genes, conditions based on severity, carrier frequency, and clinical validity. And then ACOG also recommends offering carrier screening to all women who are pregnant or planning a pregnancy. Ideally, it should be performed in the preconception setting. And this is a role that we can all play. I think we have so many things to work on with our CF patients. I think sometimes we don't think about offering these things well in advance of when they are going to be planning a pregnancy. And obviously, many pregnancies are unplanned. So even if they are far away from a planned pregnancy, these are topics that could be discussed. So with ACOG, the core panel also includes CF, SMA, and hemoglobinopathy evaluation. They support patient choice for individuals who may opt into more comprehensive panels. And as many of you may know, there's panels that include over 800 conditions. So we need to be able to kind of at least have an idea of how do you explain to somebody the difference between a carrier screening panel that has 2 conditions versus 800 plus, and how do you help guide that discussion about anticipatory guidance about what are these tests, what might you want to have, what are the benefits and limitations of doing these tests. So for people who are not regularly doing carrier screening discussions with their patients, I just included some select talking points about carrier screening. Obviously, we all know it's voluntary. You do not have to have carrier screening. It's just something that we are supposed to talk to you about and let you know about so that you can have the option if you want to have it. The right answer is always, yes, I want to do carrier testing. No, I don't want to do it. Maybe I'll have it done during this pregnancy, or maybe I'll do it before future pregnancy. All of those are the right answers. And lots of people say to me when we talk about carrier screening, oh, none of those other conditions run in my family. And that's a very common misconception. As we all know, carrier screening is aimed at looking for carrier status for conditions that are not running in the family. So that's an important piece that I think sometimes people don't understand right off the bat. So they also need to understand, just having a basic idea that even if their carrier screening results come back negative, that there is a residual risk that they can be carriers. So the risk for that condition for their baby is not 0, but it's very, very low. Usually, they need to understand the difference between autosomal recessive and X-linked conditions, and that if the mom is a carrier of an X-linked condition, then that alone puts the baby at increased risk for that condition. Sometimes carrier screening can also come up with implications for carrier status. So people who are carriers can also have health implications themselves, and they need to understand that so that they have true informed consent. Also, sometimes we'll find out that a person that has carrier screening actually has 2 variants in trans for an adult onset condition. So you have to also be ready to just at least place those important pieces into their minds, because what happens often is that in the OB setting, they'll just usually have like maybe a discussion, maybe a few second discussion about carrier screening, and you could be somebody who actually has a little more time to review this with them, even if you're not the one who's going to be eventually facilitating that discussion. The way that I usually explain, because somebody will say to me, people will ask me, so what are these panels and what conditions are on these giant panels? So someone once told me the best way to explain these are they're usually conditions that can affect a person cognitively, they can affect a person physically, or if identified early, they can be treated more effectively. So that's kind of a nice umbrella and how I usually use to describe these conditions. Whether a person, decides to pursue carrier screening or not is a personal decision, and each person really has to think about, is this information going to be helpful or not going to be helpful prior to a future pregnancy. So I kind of talked about all these things. We need to think about, is this a person who may benefit or may want to know about VVCCs? So if that is the case, if they choose to uncover VVCCs, then do they know what they need to know? Do they understand the difference between a CFTRopathy versus a CF diagnosis? The goal of carrier screening is to provide very careful anticipatory guidance, which will hopefully minimize regret regarding potential results. The last thing you want people to be like, oh, I didn't want to know that. I really wish I would not have done carrier screening. That's what I try to avoid. Ideal situation is genetic counseling before genetic testing. I would love that to be a phrase, although obviously it does not imply that every genetic test requires genetic counseling, right? We get that there's nuances to this, but in this setting, genetic counseling before genetic testing when individuals want to have VVCCs uncovered, because I feel like there's a lot of information that people don't really understand about VVCCs. So it's important to understand all the differing phenotypes. So if a partner wants to pursue testing that's going to uncover VVCCs, it's important to know that different labs have different policies about uncovering VVCCs. Sometimes you'll have to fill out a form that if you don't want to uncover VVCCs, you would do it this way. But if you want to uncover VVCCs, you would want to do it this different way. So there's just different lab policies that you have to know about. Sometimes you'll get the initial report and then you'll have to request the supplemental analysis. For example, if you want to know if the partner carries a 5T, 13TG, you have to kind of go down this other alternate path. So genetic counselors can see people with all different indications that may require additional referrals. So for example, people that have CBAVD and they are wanting to learn about any reproductive options, sometimes they're going to want to know, should I be thinking about IVF, and should I be referred to reproductive endocrinology? What do I need to know about reproductive endocrinology? It's actually really interesting because if we can set the proper expectations for what patients can expect from reproductive endocrinology, it makes a big difference. So there is, if you haven't been familiar with this guidance, and a lot of genetic counselors were actually involved in writing these practice guidelines but the American Society, ASRM, American Society of Reproductive Medicine, has practice guidelines about important aspects of IVF and PGTM, pre-implantation genetic testing for monogenic conditions, which would include cystic fibrosis. So that guidance is amazing. It basically says, okay, this is the part that I wanted to get right, which I don't know why I was having a hard time with this, but okay. So communicating limitations surrounding the feasibility of PGTM is essential to manage patient expectations. So that if they know the benefits and limitations related to PGTM, at least the basic highlights, it can make a big difference in how things go for them. And another thing that I didn't always know is that pre-implantation genetic testing for monogenic conditions is generally performed by linkage analysis, with or without direct variant analysis. So linkage analysis involves, as many of you know, I probably don't even need to say this, but some of you may not, examination of one or more unique DNA markers located adjacent to the variant of interest, which are inherited alongside the affected and unaffected alleles, to overcome the risks of allele dropout, which is the failed amplification of one allele. Linkage analysis has traditionally been considered the gold standard for PGTM. What that means is that we need to just let the patients know that relatives samples may be requested. And so that makes it tricky for some people, especially if they don't have those types of family relationships. So I think that we can help set the stage, even if we're not going to be having those final discussions, we can really learn more about this so we can help our patients have proper anticipatory guidance. So we can also facilitate discussions about CFTR modulator medications and pregnancy as part of our CF care team. We never work in a vacuum. We have our CF care team, and so each of us fill a certain role in this process, but I think that it's important for us to understand enough about this so that when patients ask us questions, we can go into this. They might then want to know about, well, what exact steps do I need to take? Because my baby's IRT levels may be thrown off if I'm on a CFTR modulator medication, and we need to be able to give them those anticipatory guidance. So here's an example. I had a patient who has cystic fibrosis, a person who has cystic fibrosis, and she has known CF-causing variants. She wanted to have carrier testing for a large panel, and so of course we found her 2 CFTR variants, but we also found that she carried 2 other variants that are pathogenic in a gene that's related with an adult onset retinal dystrophy type of a condition. So the first thing that was helpful that we had talked about is that sometimes these carrier screening results can show us a result that we need to do further testing from relatives. So one of the first things that we did is said, hey, are your parents available so that we can know whether these 2 variants in this other gene are in cis or trans. So phasing is an important thing, and these big carrier panels can uncover these types of complexities. So also it turned out that her husband is also a CF carrier. And this was really hard for them because obviously some of our families are going to not be overly concerned about having a child who has cystic fibrosis based on their own personal experiences. But this particular individual has had a pretty rocky health history. It's really, really, really hard for them. And it was a very heartfelt decision that they said that they needed to move forward and meet with a reproductive endocrinologist and consider IVF and PGTM. So you have good connections with the GC in your your reproductive endocrinology. You know all the things. You set them up with the right expectations, and they go and meet with your team. So I usually have like a summary note. I have a smart phrase that either myself or maybe some people here, it might be somebody else on your care team that does this, but just a summary for either your maternal fetal medicine provider or your reproductive endocrinology provider with important details about CF. So, just the usual things. So genotype, sweat test results, pancreatic status, whether they're on a CFTR modulator medication, do they have CF-related diabetes, pulmonary function, what is their plan? Would they like to do routine prenatal tests? What about their carrier screening results? What about their partner's carrier screening results? And what about any specific guidance from the CF care team? So we usually tell our families that are our people that we should see them about 1 month postpartum. So, if there's anything specific to your CF team, you can always include that. And I feel like that information, any specific guidance that they may not know. So having a OGTT done for diabetes screening a little bit earlier in the pregnancy instead of the usual just 28 weeks. And what about vitamin A and making sure that that's not too high of a dose? So all of those things are really important and can be included in a summary note, which really helps us make sure that everybody is on the same wavelength. And the patient then doesn't have the burden of coordinating their providers, but we take care of this for them. So there's so many resources if you're new to the CF arena and you don't have as much information as you would like about CFTR modulators. A really good place to start, especially for patient information, and also for guidelines, is on the CFF.org, obviously, and they have lots of information about CFTR modulator therapies. Here's just a couple of papers. There's a lot out there. So women with CF and their pregnancies, as I mentioned earlier, we can be the bridge to bridge these families with the state lab, if we have some special requests for these babies, we can be the bridge to this baby's primary care provider. If we need to bridge them to special monitoring for liver enzymes or cataracts and such. So I basically have some, things created. So this initial thing is our center's state lab special request that can be facilitated by a GC if desired by parents. So what we do is if they're delivering in our hospital, we'll share this with our L&D team. We'll mark off the proper box, and that's the only thing the nurse has to do. So for example, if I were to mark off this maternal CF box on the newborn screening card, they will just write maternal CF. So we have made those arrangements with our state lab, and they've told us what they want to know. They don't want a whole paragraph on that newborn screening card. They just want some basic details. And then usually I'll also message the state lab and say, hey, state lab, just so you know, this person is going to be delivering around this time, and it's worked amazingly well. If they're not going to be delivered on our institution, then I will print out our special request paper, and I'll give it to the families, and they're really, it's worked out really well. They'll then share that information with the newborn nurse. So GCs can really help bridge lots of these different aspects of CF care. So we also have note, it might look familiar to some of you out there because it's probably taken from some of you with some basic changes. Thank you for sharing resources out there. There's so many people that have used their resources. So let's see, what did I want to say here? So we can learn from each other. That's the bottom line. So many of you already know about CFTR2, huge resource. Many of you might know about CFTR France. That's another variant database, which is an excellent resource. Our special interest groups. And if you are a genetic counselor and you haven't worked in a CF center for very long, you don't feel like you have the good picture of how to set the proper expectations for a baby that's either going to have cystic fibrosis or a CFTRopathy, reach out to a CF care team or a CF genetic counselor. I've had it happen so often where a patient meets with a genetic counselor in the prenatal arena, and they are amazing. But, just like if I had a patient that was going to be diagnosed with a condition that I really didn't know that much about, I could read about it and know about it in black and white, but actually knowing the condition and knowing what state of art care for that condition makes a big difference. So if I had that type of a thing, I would reach out. So if it's a neurogenetic condition, I would reach out to my neurogenetic colleagues and say, can you tell me more about this? So in the same way, if we are working in the prenatal setting, I think reach out to your CF friends. There's some basic differences. You guys know this very much, that there's differences in variant classification between ACMG and CFTR2. So it's really important that we all understand very well what a variant of varying clinical consequences and that there's no ACMG equivalent. And the other part of this is that there are non-CF causing variants, and we have to be really careful with this interpretation. So while the data is clear that these non-CF causing variants, when in trans with another CF causing variant, they do not cause CF, but they may cause CFTR related disorders or a CFTRopathy. So it's really important to have the proper communication regarding that. So we often we'll need to know a lot about CFTRopathies and CF SPID. I found that sometimes when a kiddo has a CF diagnosis, almost it's easier to counsel those families than when they have a diagnosis of CRMS. So and the more you know, I feel like, and the more you practice and have expertise in this, the easier that becomes. So if you are somebody who needs to know more about CRMS, there's so many resources, but you can start with cff.org. They have lots of information that's patient-friendly, and they also have guidance on specific practice guidelines and other papers. So what we need to know is that when we feel uncertain, and this might be familiar to you guys, I'm using a couple of slides from a different talk too, provider uncertainty. So is the uncertainty, for example, about CRMS, present because the clinician doesn't know enough about the condition and the prognosis. But this information exists and the provider is uninformed. So we really have to question ourselves when we feel a great deal of uncertainty about something. When it comes to CF and CFTRopathies, we are fortunate to have a wealth of knowledge, and there is tremendous CF experience and expertise in this community. Seek out information, recognize when you don't know enough, utilize resources and your GC friends. I'll stop saying that eventually, but genetic counseling is an art and a skill to be sharpened. It does not help to talk about all of the unknowns, although I'm not saying that there are no unknowns. Of course, we talk about the things that are unknown, but overall, it leaves the family in darkness. We want to bring the picture of what this is going to look like for the baby back to them. And Becca Mueller, I was just telling her that I was so happy that I always have this idea of bringing the picture of the baby back, and I was so happy when I heard her prognostic imagination. I was glad to have a term for it. So we know a lot about CFTRopathy. When there is scientific uncertainty, this is not helpful to families. We just don't know. We just don't have any data. We have never seen this before. No available research. Find resources that help you explain this in a way that's meaningful to families. Find examples or analogies. I love Eleanor's light bulb. Instead of a on and off switch for how much CFTR protein is present, a dimmer switch that dims down the production of the CF gene to make less CFTR protein. I love that. And it helps individuals avoid the temptation to give more weight than deserved to uncertain findings. Try a different approach. While there are more questions regarding this, what we do know is scientists are curious about whether this means X or Y, and we are still learning. In the meantime, what we know is we will take the best care of your baby, and we'll stay on top of any medical issues that arise. You are in great hands. Our plan is. So just that kind of language helps families. Unknowns don't help a lot for families when that's the focus of conversation. So this is a family that we follow John, who has cystic fibrosis. John's parents are both CF carriers. I had informed the family, given family letters, share this with your siblings. Fred had shared this information with Sarah, but she never did CF carrier testing, which is fine. She was then pregnant, and because I had talked to Jan about the availability of single gene NIPT for a future pregnancy for her, she had mentioned that to Sarah. Sarah wound up doing single gene NIPT. So as you know, we can not only do non-invasive prenatal testing for select aneuploidies like trisomy 21, 18, 13, but we can also do single gene non-invasive prenatal testing for monogenic conditions like cystic fibrosis. So it is a screening test. It is not diagnostic, but it can give you a high risk or low risk result. So this baby for this other couple now winds up having a high risk result. She is a carrier. Subsequently, they confirm that the father of that baby is also a carrier. Now you have a very complex psychosocial situation. The biggest worry for this family is they know CF guidance really well about the CFF respiratory precautions and infection control guidelines. So they, of course, ask me, what's going to happen if there's two cousins that have cystic fibrosis? These are the only two siblings. They had another sibling that passed away, which was a traumatic thing for the family. But so now these two cousins, if these families can never get together. So the CF care team is going to be really important in guiding these conversations. So the other baby is in a different area, it won't be part of our CF care team. That's the other thing. Not all CF care team providers are going to have the same recommendations. So, we can help set the tone. We have expertise in this. Genetic counselors have practice-based competencies. We can facilitate decision-making process. We can provide anticipatory guidance. So we can say to the family, you're going to have to weigh what each of these kiddos are told by their CF care team. But in the end, you as a family get to make decisions about these two kids. This is a family decision, and you need to help, some of the things that might help you think this through is, what if we decide that we are going to just be together as a family? What if we decide we're not going to be together as a family? What if we decide we are going to continue to get together as a family, but what if one of the kiddos has a positive culture? Like just to help, we can facilitate these kinds of discussions. So, related to single gene NIPT, it's a good screening test. It is not diagnostic. Results can take over 3 weeks to get back, may require a second blood draw if you don't have enough of a fetal fraction. You can, if you know early enough, you can bundle the aneuploidy NIPT and the single gene NIPT for CF so that the regular NIPT is not done through their OB's office, which would be then 2 charges. You still want them to understand that CF newborn screen, if CF newborn screen is positive, a sweat test will be recommended if that's your state's algorithm. I was going to go through that. So this is a sample report for single gene NIPT with a high risk result. So it's important to understand that there's used to be just one lab providing this. Now there's another lab that's getting into this arena, but they have different methodologies and they don't have the ability to look for every mutation. So if you have a couple who are carrier couple, you really want to reach out to the lab if you have any questions, if it's especially a uncommon mutation, whether they can actually provide a risk result for this patient. There's going to be a wide risk range. So for 2 people who carry F508del, usually the high risk number that they can get up to is 9 out of 10. And then it can get as low as something like 1 out of 400 or something. Sometimes you're going to have results that put you smack dab in the middle. And in that case, it's really not informative. So these are some things you can set up the family for so that they're not disappointed. So this is a case that I'll quickly go through. And am I over? Way over. Okay. I'll just I think I have like a couple more slides. So this is a family member that messaged me. She said, I hope you're doing well. We had previously met in 20 whatever when we were pregnant and found out that I was a carrier of 5T variant and my husband was a carrier of F508del. You were unbelievably helpful in giving us information for what we could expect with our 2 variants. FYI, our daughter turns 1 soon and is doing great. When I first spoke to the couple who were actually referred to me from a GC who was looking for a Wisconsin GC to talk to this couple, it turned out that she didn't know, but she was a carrier of 5T, 12TG. The couple was extremely well informed. They had already met with a CF Center nurse and a GC that was not a CF Center embedded GC. They were looking for anticipatory guidance and a prognostic imagination for what would their baby be like? What is this child going to actually be like? And that is the piece that was missing in all of this, is that they didn't really understand, even after having a discussion about CFTRopathy, about CRMS, they still really didn't understand it. After we talked, they felt comfortable. They were still, their CVS was scheduled, I think, in like 2 days. They still carried through and had the CVS, but by then their plan was just to use that information for planning for the birth of a baby or for, just because they needed peace of mind at that point, because they'd spent so much time thinking about the possibility of their baby having these 2 CFTR variants. She messaged me back another time and she was like, hey, I just wanted to reach out to you because my relative is also in the same situation. That relative also has 5T, 12TG. And that person's partner also has F508del. And that couple, could that person reach out to me? I said, sure. So I wound up talking to that family. And they were way down the path. So they were basically saying, that they're feeling like the time is ticking for making a decision on how they want to handle this pregnancy. And they had not met with a genetic counselor. So many things had happened. I really feel like in the early part of when these VVCC results are reported out, especially when you have a carrier couple, genetic counseling by somebody who has expertise is critical in how the rest of this is going to play out. And of course, we all have a role in meeting with adults who have a late diagnosis of CF, and we can play a huge role in setting the tone of hope with these individuals, provision of updated information, support, and anticipatory guidance. And with that, I'll end that. Sorry if I talk too fast.
Is this working? Okay, yes, it is. Does anyone have any questions for Sumeda? If you do, you can stand up on the mic there or send something through the app.
Is this on? So you made a great talk as always. I'm Christine Quinn from Children's Health in Dallas. I'm curious a little bit more about the special request lab form. Is that through your state lab? Is it on the newborn screening card? Is it something you developed?
I'm sorry. No, that's actually through the lab.
It is. Okay,
Yeah.
your state newborn screening lab. And
No, I'm so sorry. I did not say that correctly.
Okay.
The lab that does the carrier screening.
Okay.
So, yeah,
So you're giving it to families?
no, we're completing it. So can I say the name of the lab? It was on there, but, okay. So that's for Natera.
Oh, okay.
So basically, if you want to have VVCCs disclosed, you just have to do this different process.
We might be talking about different things. It was like, it said like St. Vincent,
Oh, I'm so
and it
sorry.
said like
so
parent or like maternal CF, sibling with
Yes,
CF, like
yes.
the way to give, like kind of a more formal way to give the lab some information about the baby's newborn screen as opposed to like, I send an email. But this seemed like a really nice form that's maybe with your newborn screening card or on the website. I'm curious about that.
I literally made that up in a Word document, and I just asked the newborn screening lab for the particular verbiage they need and how much information they need. So our state lab gave me guidance about exactly which, what they would want me to say. And what I would have said, it would have been volumes, right? They're like, no, just say maternal CF. Or sibling with CF, and then check off the box, make sure that the newborn nurse writes that on the newborn screening card, and then we'll have everything we need to do the proper testing. So yes, the guidance came from the state lab, and then we created the form, and we give that to our patients. Sorry.
I'll follow on that question. Are there multiple CF centers in your state? Like, is that your center or are all centers that go through your state's lab using?
So we have multiple centers in our state, and Anna, I know that we've like talked about, where's Anna? Oh yeah. I know we've talked about kind of the same form, right? Do you also use the same thing?
I haven't been using that form. I've more just been directly emailing the team at our state lab, but we definitely have talked about that form and I like it. I think I just need to probably get more buy-in from like our L&D team of like who can be responsible, like to take that on and who's the contact. We have had those conversations.
We have a really nice group for our CF newborn screening lab, and all of the genetic counselors and the 5, well, we're missing one right now, but most of us will meet on a regular basis, and then we try to be consistent in our newborn screening for CF process with our state lab.
Any other questions? Okay, so on to the next one. I'm happy to introduce Emily Calamero. She is a certified genetic counselor at the University of Rochester Medical Center in New York, and she provides pediatric genetic counseling. She supports the pediatric cleft and craniofacial team as well as the pediatric CF care team. And since joining the U of R in 2016, Emily has supported the CF care team, but recently joined as a core team member in the summer of 2025. Additionally, Emily serves as the Associate Director of the MS in Genetic Counseling Program at the University of Rochester School of Medicine and Dentistry. Very busy woman.
Thank you, Charlotte. So this feels a little weird because there's so many people that I really respect and admire in this room. I should not be here, but thank you so much. So I am going to talk about today integrating genetic counselors into the care team. So Sumeda, you set me up very nicely. So we're all on board with like we're important and we need to be involved in the care of patients throughout their lives. But how do we do that? And what are the strategies? What are the models that we're using to do that? So that's what I'm going to talk about today. No formal disclosures, but I do receive some funding from the CFFSIP award. So this is just a brief outline, but I'm gonna go through, just review briefly the position paper on redefining the care team. I'll talk about some current practices and research on practices of genetic counselors within the team. We'll talk about some models from the position paper about how genetic counselors are engaged and involved. Some facilitators and barriers to genetic counseling integrating into these teams. And then I'll end with sharing my experience at the U of R. So we're all, I'm sure, familiar with the paper by now, but just to review, last year, the position paper came out and recommended a new structure for the care team. And so at the core of the care team is obviously the person with cystic fibrosis, but surrounding them are providers that are supporting patients with cystic fibrosis or people with cystic fibrosis, these providers in the core team will serve them no matter who they are in their lives. And the essential providers and then the trained and trusted providers may only serve or provide services to a subset of those people. And so 3 new players to the core team, mental health counselors, pharmacists, and genetic counselors, which is why we're here today. So there's actually been a decent amount of research done and showing that genetic counselors are engaging and are involved in care of, on these care teams, not just in care of people with cystic fibrosis, but actually integrating into the specialty care centers. And so I just pulled some papers. Many of you are authors in this room on these papers, documenting and researching how this is actually working. But just to say that this is happening. So this is not so much a question of if this is going to happen and should we do this. I think that's pretty well established, but more of how and when and what do we need to be able to do this better and effectively. So how? I think the place that we really need to start is by agreeing that this is going to be very center specific and there's no one right model that this is going to follow. And so this will vary depending on the size of the center, the state in the center that the center is in, the resources available, is there funding, is genetic counselor availability there within the institution or in the state. And then the proposed models that I'm going to go through in more detail, these came from the position paper. So if you read the paper, there's a nice supplemental table that comes with it that walks through these proposed models. Some of these I know are actively being utilized, and others are more hypothetical or are being used for other conditions and not specific for CF yet. In 2019, Eleanor Schwind and Karen published the practice variation paper that talked about how genetic counselors are integrating into care teams. And so this was not validated, this was not IRB approved, but a couple of weeks ago I sent out just like a quick poll to see if that had changed to the National Society of Genetic Counselors, CFSIG. As of Tuesday, there were 114 members in the SIG. I don't know how many are like actively involved in the SIG or providing care still. But I got a whopping 18 responses on the survey. So obviously, not IRB approved or anything, so take this with a huge grain of salt. But I did get 18 responses, and you can see responses here that over half of them are what I'm calling embedded. So these are genetic counselors. I'll go through in a minute the specific model, but who are like hired through the care team, either full or part-time. And then almost all of the rest of them are engaged within the same institution as the care team. So I think probably 18 of you are in this room who responded. And I think this is totally biased because the people that responded are more likely to be the ones that are engaged. So I don't think this is a good representation, but could be evidence that we need to look into this more and see how things have changed over the past 6 years. So my survey was super fast. It was 2 questions. That was the first one. The second one was, has your role or involvement with your care team changed since last year's position paper? And I don't know that I was surprised by this, but I think 5 people are either it has changed or it will be changing. So obviously this does not prove causation, that the paper was the impetus for this, but it is interesting to note that more people are being integrated or their positions are changing. Disclaimer that I was one of them. So I'll talk about a little bit more detail about each of these models. So what is the embedded GC? And this nomenclature, I will say, is a little bit different from Eleanor and Karen's paper from 6 years ago, where I'm using the word embedded and engaged differently. And in your paper, it was engaged meant kind of both scenarios here. But embedded, either full or part-time, meaning they are hired through the center, and they have dedicated FTE that's allocated for the care of people on the team. So GCs might be present for all of the CF clinics or just as needed. So I physically am present in the clinic now, but if there are patients that day that don't need me, I don't physically need to be there perhaps. With this model, most likely the revenue from any GC billing will go back to the care team. That should make sense. And then with this model too, there's protected time for patient care and potentially other activities like research or helping to make the model and the care, the multidisciplinary team more efficient and things like that. And obviously this would require financial support from the care team, either internal or external funding sources to do this. Sorry, my slides seem to not have come through. For the engaged GC, these are genetic counselors that are engaged within the same institution as the care team, but they may not be they're not formally part of the care team itself. So this was me and I'll talk about this at the very end. This was me for most of my career, where I was hired through clinical genetics, but then providing care by referral from the care team to provide genetic counseling in clinical genetics. And so these patients they might be scheduled in person, where the genetic counselor can join in the care team and provide genetic counseling during those visits. This could be genetic counselors doing telemedicine visits on their own, or as I was doing most of the time, I would schedule them on my own GC clinics, so separately through that. So I think the slides are not.
Is there any way we can pull up and put the other slideshow within the orchestra?
There are 4 more models.
Which one?
The first one.
Cool. And to go back, just hit escape and then click on whichever one you want.
What was that?
To go back, you just hit escape and then click on whichever one you want to go back to. When you want to go back to the other one.
Okay. Sorry about that. Oh, here. Okay. All right. So the third model are genetic counselors that might be integrated directly into the Department of Health within the state. So this was actually, I highlighted the work in California, where the Department of Health was actually providing genetic counseling by telephone counseling services free to families, where genetic counselors would be contacted directly through the Department of Health to do this as part of their long-term newborn screening follow-up programs. And so counselors in this capacity theoretically could be doing this in person, but in this paper and in this study, they looked at specifically telephone counseling. This was talked about a bit yesterday if anyone was at the QIC meeting, but what I found really interesting about this is that there was actually a low uptake of genetic counseling. That patients receiving carrier status, actually only 12% of them elected to receive that genetic counseling service. So something more to think about in this type of model. And so I've combined on this slide models 4 and 5 because this talks about expanding the geographic regions where genetic counselors are serving their patients and where their patients are coming from. So the first model would be within the same state. So this is highlighted in the current work that we're doing with our SIP study. In New York State, we are doing an interinstitutional collaboration of all 10 specialty care centers where we are providing trying to expand the access to genetic counseling services through the collaboration. The idea behind this and the goal was to engage genetic counselors at each of the 10 specialty care centers, and then support and train those genetic counselors to be CF trained genetic counselors for those centers. We were successful that 8 of the centers in our state were able to identify a genetic counselor to do that in the institution. And the remaining 2 centers, Charlotte and I are have been providing telehealth genetic counseling visits for them. And so I will shamelessly plug our poster 333. Come visit us for an update on the status of that project. And then I'll highlight a couple of other studies, but Stalker et al., their paper published work demonstrating that you can also do this across state lines. So again, if you were at the QIC meeting yesterday, this was mentioned too, where patients from Connecticut and across the country who didn't have direct access to CF-trained genetic counselors were being provided genetic counseling by CF-trained counselors in Florida. And so the results of that were actually wonderful, and it was really proven to be very effective. And so what I think this suggests, and is part of their paper and their work, is that genetic counselors can most likely, and did in this study, support multiple care centers. And this could be a really cost and financially feasible way to support centers that can't, maybe don't have the resources or access to genetic counselors within their same center. And so the final model that I'll talk about is genetic counseling through a disease-specific advocacy organization. I think for us, we're all thinking about Cystic Fibrosis Foundation would be the advocacy organization that would make the most sense. But this, so I've highlighted here the alpha-1 antitrypsin deficiency disorder. They have the Alpha-1 Association, and through the Alpha-1 Foundation, they're providing genetic counseling services free to patients who need that. And so through this, the patients are contacting the foundation to receive these services by Alpha-1 trained genetic counselors. And so I think this would be a really nice way to do that for people who may not have a lot of trust in the medical system, who, you know, they may have a lot of trust in the foundation. So people are going to the foundation, going to the website. They're already placing trust in the foundation. And like, who is this random counselor? Who is this random person? So theoretically, that's just my thought, but that might be a way to engage more people in genetic counseling if that was something offered through the foundation. So all of those models are really nice, and we all probably agree that this would be really nice and needed. But how do we do that? And what are the things that are going to help support integrating genetic counselors into these centers? So again, I want to really highlight, like, this is going to most likely be center specific. We need to get really creative and think about what works for your center, with your resources, with your people. And so there's no one right answer. And I think that's highlighted with all the models, but just thinking about your center, all of you in this room are probably thinking this model may work, this one may not work. What will really be helpful to doing this is developing a really strong, sustainable, and effective plan for how to do this. So if you just say like, oh, this is nice, this is something I want to do, right? That's not going to help move this forward. Identifying key factors that are going to support the proposal is really key here. So we need to be able to identify the need, and how and talk about and prove how outcomes for people with cystic fibrosis are better with the integration of genetic counselors and these services. With the care model, that graphic, obviously people with cystic fibrosis are at the very center. And so we can't forget that. We need to remember that this is why we're here. We are here to help these patients and their families. And so if we can't prove that what we're doing is really improving their outcomes, then that's really not going to work. So we just need to, I think it's easy to get lost sometimes in what we're doing day to day, but really keep in mind, like, the work we're doing is to support these patients. One of the examples, I think that this was really big for me and my practice, was the expansion of newborn screening. So I'm from New York. We now have sequencing as part of our newborn screening. We are returning more complex results. And the majority of the patients that I'm seeing at my center are not the straightforward patients with cystic fibrosis, right? Lots of 5Ts and lots of I can't even say the acronym right now, but a lot of these uncertains. Thank you, Karen. So if we're doing that, right, this is evidence. We can use this as evidence to support what we're doing in clinic, that these are complex results. They need a lot of care and attention. And so identifying some of these factors that are going to support this is really key. One of the things that I would anticipate is going to be really helpful is increased billing practices for genetic counselors. Last year, we were all very excited that we got a new billing code. So 96041 is now being utilized by genetic counselors, specific for genetic counseling services. And so we can, the reimbursement rates are still kind of in flux, but this will hopefully be helpful to getting some reimbursement back for our services as well. And this is not tied to licensure. So I practice in New York. Unfortunately, New York still does not have licensure, and I am still able to bill. So this is something that is really helpful to this effort. We need to, and Sumita, you talked about a lot of the evidence and the practice guidelines, but we need to lean on those and use those. So supporting evidence, again, the resources, the position paper, the guidelines, those will be really helpful. And then back to kind of financial, not just billing, but are there other revenue sources that can be helpful? So not just the direct billing, but identifying grants or other research funding sources to support the genetic counselor on the care team will be really helpful. I don't know how many of you genetic counselors know that this business toolkit exists. I did not until a few months ago, but the National Society of Genetic Counselors developed this toolkit specific for cancer genetic counselors, and it is a long document. I would recommend you take a look at it. It's really wonderful. So they developed this toolkit to help genetic counselors advocate for themselves in cancer centers. And I think I'll share another slide about some of the resources within this toolkit, but this could easily be modified for CF genetic counselors. So I'm going to put my program director hat on for just a minute, and I think this would be a really great project, a thesis project for a student. So if any of you have students that might want to work on that, we should talk. So these are just some screenshots of like what is part of the toolkit, and it really gets into the nitty-gritty. It really helps break down, how do you make this proposal? How do you make your case? What questions do you need to be thinking about? What I love is on the bottom right, they add common challenges that you should be anticipating when you're talking about this. And so not only are you building your case really with all the support and all the positives, but it also prompts you to think about what you should anticipate being barriers, and then you can use that to go into this and really have some evidence or have some solutions to the barriers from the get-go. So we'll talk a little more about the barriers, billing and reimbursement. I just said we do have a new GC billing code, but we're not all able to bill. So even in New York State, I am able to bill at my institution for GC-only visits. I have a colleague at a different institution that cannot. And so not tied to licensure, but there's just various reasons why we can't bill all the time. I think one of the main factors here is going to be the high demand for genetic counselors. All of us in this room are aware of this issue, that we're really most of us are at our capacity at this point. So I want to be clear that this does not mean that there's a shortage of genetic counselors. We know this is not true. So it's different from a few years ago. We do not have a shortage of genetic counselors. The problem I foresee is that finding genetic counselors who can allocate some of their time to a care center may be difficult. So, for example, in my center, I still work in general genetics, general pediatric genetics. Our wait list is over a year for a routine patient. That's not sustainable. And we have 4 pediatric genetic counselors. So if you are going to ask one of the 4 of us to spend a day, 2 days to dedicate directly just for cystic fibrosis, the administration may really push back and say, like, absolutely not. And so I think for care centers, hiring a full-time genetic counselor may be really prohibitive. And that may be too much of a leap. That would be the ideal. But then finding people who could just do a 0.2 or a 0.4, that may be more of the challenge that I'm foreseeing. Unfortunately, I think this is still being documented that the buy-in from some centers, center directors, is just not there. So center directors, I have great center directors. They are here. They're supporting me. They have bought in, but not all of the center directors have. And so if they don't see your value, if they don't see the scope, if they don't understand the scope of your practice, they're not going to advocate for you. And I think the advocacy by the care team is really, really, really critical. I would be remiss not to talk about logistical challenges. Sometimes we're all so busy and we think about all of these different things going on that all the nitty-gritty things can just like add another layer and it just gets to be too much. So logistically, if you're integrating another team member in the care team, you're going to extend the time of those visits for patients. So this will impact room utilization and room turnover. And so it's not something that is not overcomable. But it's one more thing to be thinking about. And so does your team have the resources and can you get creative in how you're going to do that? How are you documenting? So we spent a lot of time talking about how are we documenting my visit in the care team when I joined in July. Sometimes I'm having my complete separate notes. Sometimes this is a joint note with another provider on the team. And then what does that mean for billing? So all of these things, just logistical challenges. Where are the patients being scheduled? Are they on my schedule? Are they on their schedule? Like just a lot of things that you need to keep in mind. So again, these are all not insurmountable things, but will be hurdles that you have to go. So I'll end by sharing a little bit about my personal journey, my evolution of my role at the University of Rochester. I started in 2016. I was full-time clinical general pediatric genetics, but part of my job when I was hired, I knew that I was going to be seeing all of the positive newborn screens for cystic fibrosis. There were other counselors that were doing the other positive screens for newborn screening, but I was to be doing the cystic fibrosis ones, and I loved it. These were mostly GC-only visits, so our geneticist was not seeing them with me. When I started, I was not billing for them. Throughout the years, I began, because I was able to be credentialed with our insurers, I was billing for them, but for most of that time, I was not. Some of these visits were in person through COVID, and then after, more of them became telemed visits. They were either scheduled during the cystic fibrosis care team's visit, where I would physically go down and join the team, or I would see them on my own. And then when I was able to bill, the revenue from my visits came directly back to clinical genetics because that's where I was hired through. In 2021, I was approached by my then center director, Karen Voder, and said, hey, there's this project going on. I think you'd be really great. Are you interested in this? And that's how I got involved with the CF Genes project, poster 333. And this really changed the game for me. So around this time, I was also transitioning my career and became associate director of our master's genetic counseling program. I could not manage genetic counseling in general pediatric genetics, craniofacial clinic, CF patient visits, and all of the master's directing. It was just far too much. So it was really at this time, it was like a perfect storm of things. I was looking for ways to focus my career and my time. And so my hope is right now that I will get rid of my general pediatric genetics clinic, but to be determined. So I started working with this project, and this is when I began working with other providers and other centers in New York State to do telemedicine genetic counseling across the state, and it's been great. We've had really good success with that. So that had changed a bit of my role. Those visits, because they were part of the grant, were non-billable. We don't charge for those patients. And then I'm very excited to share that as of July 1st, I became an official embedded core member of our team. So I am now 0.2. I have 0.2 FTE dedicated. So every Tuesday you'll find me, and most of our New York centers apparently have CF clinic on Tuesdays. You'll find me in clinic and working in person with these patients. I still see some on my own telemedicine in the mornings. These are usually scheduled during the CF visit, but sometimes they're separate. And then I'm there to support the team however they need me. I wanted to look back because that was a really natural, for me, it felt like I didn't intentionally do this. I didn't say like, this is my plan 5 years from now. This is my plan of how I'm going to get there. It just really happened very naturally, and the timing of things came together very well. But I did look back and thinking about putting these slides together about what will be facilitators to this integration. And I think I've identified a couple of things that really helped in this journey. So as genetic counselors, we are fierce advocates for our patients, for our families, and we do this for ourselves, or we can do this for ourselves. And so promoting yourself on your team, letting them know you're there, showing them what you can do, this is really critical. So I was talking to my coordinator last night, and I laughed and I said, I really did infiltrate in your team, and I just kept showing up. And it's true. And I think that building those relationships was really, really helpful. I think being in New York State, where the newborn screening algorithm was updated and changed, was really crucial because a lot of these challenging patients are now coming, and there's a need for more genetic counseling in some of these nuanced ways, as we've heard a lot already. And then just using telemedicine, I think this was crucial too. Through the CF Genes project, I received some funding, so that helped with the financial aspect of getting me on board a little bit more, and just using telemedicine that's here through all of this. But I think that's really helpful to add some flexibility to the role. And then unfortunately, the position paper I did learn from my center directors was not helpful that much to my position. Helpful, but it was not a primary factor to how I was hired on. I am able to bill, so I get a little bit of revenue to support that. And then the co-documentation, we get a little bit more for billing there. But what was really helpful was we have a specialty pharmacy that creates a lot of revenue for our center. And so our administrator was able to use that as justification to hire me, which I actually didn't know most of this until I was prepping for this. So it was really good for me to understand how this came about. And then, as I said before, my center directors and my whole team, they are incredible, and I really feel valued, and they really do support me. So it was not hard. There was mutual buy-in from the beginning, way back in 2016. And so I feel really fortunate to have that was not a hurdle I needed to jump over. I know I'm over time, so I'm going to skip this. And as a mom of 3 young kids, I kind of have a love-hate relationship with this term, it takes a village, or this phrase. But in this context, it really does take a village, and I'm very grateful for all of these people and more who helped me, supported me, and continue to support me on my journey and how I got here. So thank you so much.
Thanks so much, Emily. Do we have questions?
Just a comment. Thank you so much. That was so good. I totally agree with you. I think that the CF Center buy-in is the biggest piece. And based on publications, we know that once you have a a genetic counselor that's embedded in a CF clinic or engaged in a CF clinic, there's high levels of satisfaction. And when people say that they can't get a genetic counselor, vast majority of those people haven't tried. So, I think that I have experience from joining our multidisciplinary bleeding disorders team. And the genetic counselor back in 2011 said, I was like the main person who said, I really don't want a genetic counselor as part of our team because I can do X-linked. And then once I had started, after a few months, he was like, wow, I didn't really know any of these things. So, I think once you have a genetic counselor, it's huge value.
I also realized that I forgot to ask Emily, what is your one piece of career advice or genetic counseling advice?
I received 2 and I failed at both. One was marry rich, and the other was set clear boundaries, and let them be known. And I don't have clear boundaries. So do as I say, not as I do. I tell all my students, do this early in your career so people don't expect that this is what will be forever. And I did not heed my own advice.
Thank you. All right. I'm happy to introduce our last speaker in this session, Dr. Rebecca Mueller. Dr. Mueller is an assistant professor and director of research for the Master's Genetic Counseling Program at the University of Pennsylvania, where she also teaches in the program's Advanced Research Training Program for Genetic Counselors Certificate Program. Becca's background is in genetic counseling, medical humanities, and the ethical, legal, and social implications of genetics. She recently completed a T32 postdoctoral fellowship in the ethical, legal, and social implications of genetics and genomics at the University of Pennsylvania, and currently has a K01 from the National Human Genome Research Institute to investigate how adults with cystic fibrosis and other childhood-onset genetic conditions plan their futures amid shifting prognostic expectations. Thanks so much for joining us today. And if you wouldn't mind sharing your best career advice you've received, that would be great. Welcome.
Thank you so much for the introduction. It is just such a pleasure to be here in front of all of these genetic counselors who are involved with CF care. One of the more recent pieces of advice I got was from Kimberly Manning at Emory, who said that when it comes to those things that you encounter that kind of break your heart, if you can focus part of your career on that you'll have a really meaningful career. And I really appreciated that advice and have tried to take it. All right.
To switch up the slide.
Slides,
sorry.
No worries.
There you go. And then just yours.
Thank you.
There we go. All right, so I'm going to talk to you today about prognostic imagination and how prognostic messages shape expectations and behavior. My only disclosure is my funding from NHGRI. So I'm going to talk to you a little bit about the various sources of prognostic messages, prognostic imagination, how modulators have impacted how people think about their futures, and then, especially for this audience, I want to highlight what individuals have shared with me about their communicational preferences, and close by talking about the implications that my work has for clinical care and for genetic counseling. So people with CF and parents of children with CF or CF-related disorders may first learn about CF from popular culture, right? It's one of those conditions that is common enough that people can encounter it in a lot of different ways. People might have family members or just acquaintances with CF that they're learning about the long-term implications from. And of course, they may learn from clinicians and a lot of other different sources. Genetic counselors across disciplines counsel about CF, so I worked predominantly in cancer. Every once in a while, there'd be a family history of pancreatitis, which would prompt CFTR testing. And then, of course, CF has long been a part of prenatal and reproductive genetic counseling, but we do know, and I think this is the purpose of, having a group like this, that you're sort of run-of-the-mill prenatal genetic counselor who has to be an expert on so many different things may not be very familiar with sort of the cutting edge in CF, with novel targeted therapies, and they may not be comfortable counseling about those. This is strangely advancing without which is fine, but I'll keep track of it. But for all those reasons, I think that it's really critical to have genetic counselors who have a more nuanced understanding of CF. And I think, even just in conversation I've heard, sometimes your work involves almost helping families sort of unlearn the initial messages that they may have gotten about CF from clinicians and from other sources that are, again, a little bit less on top of the sort of current day-to-day care of people with CF. So my vantage points on this topic are sort of myriad. Again, I worked predominantly as a cancer counselor, but I did a little stint in prenatal, and certainly I recall my prenatal rotations circa 2010, circa 2011. At the time, there wasn't expanded carrier screening, so the conversations about each condition that was offered did take place, and I still remember this brochure and a kind of outdated median life expectancy, which was one of 3 big facts shared about CF, and that really stood out to me because I also have CF. I was diagnosed early in childhood, and now in my 40s, and it was just very clear to me that this was a very limited and really actually kind of inaccurate depiction of CF that was being so readily shared in the context of prenatal genetic counseling. And I think that experience just made me very attuned to the kind of quick stories that we tell about genetic conditions in different contexts. And some people have called this a twice-told tale, meaning simply that the description we give of a prenatal condition of a condition in a prenatal setting is often sort of more negative and severe than how conditions are storied postnatally, what we sometimes call a twice-told tale. And that's not necessarily good or bad, but I think it really speaks to the fact that whenever we're describing a condition, there's a message that is embedded within that we really need to be acutely aware of. And while we know quite a bit about how conditions are storied in that kind of prenatal context or at the moment of diagnosis, which in CF is often, though not always, with parents, so much less is known about how individuals with these conditions learn about the prognostic expectations over their lifetime. And that's unfortunately true with respect to CF, Duchenne's, SMA, you name it, there's 1 or 2 papers about how adults, as they grow up, learn the prognostic expectations. I think we're fortunate that there's this one 2018 paper by Elizabeth Dellen's team that did a number of interviews with people with CF, parents, and also clinicians. And what the team really demonstrated is that people with CF learn about the prognostic implications earlier than parents and clinicians might assume, and also that parents really want support with these really challenging conversations, right? They're hard conversations to have. So what I'm going to be reporting today are a very preliminary analysis of 18 of what will be 45 interviews with adults with CF aged 18 and up who were diagnosed before 12, so who had sort of a pediatric diagnosis, non-transplanted, and clinically ascertained through a single center. And because I think the value of qualitative research is kind of individual stories and capturing variability and outliers, and because I'm sure stories have shaped a lot of your practice in genetic counseling, rather than do sort of a synthetic analysis, I'm going to highlight 4 case studies and talk you through 4 people's stories. This just captures kind of the variability in the group of people that I spoke with, where I had a range of FEV1s represented, a range of genders, and an age range from 20 to 51. Most people were on modulators or had been on modulators at some point. And I'll be telling you the stories of Ellen, Anthony, Rachel, and Joe. Ellen and Anthony were in their 50s, so they would have been diagnosed in the 70s, both on ETI. Rachel and Joe were in their 20s, so they would have, been diagnosed in the 90s or the early 2000s and also were on ETI. 3 of the 4 had really gotten stabilized on ETI with pretty high lung function. And then Anthony's lung disease was more advanced with an FEV1 in the 50s. But both Anthony and Rachel needed sort of regular IV therapy in order to stay at their baseline. So when I asked Ellen, who again was in her 50s, how she learned about the long-term implications of CF, she recalled, when I was 9, I asked my parents, what was the trajectory? What was it going to look like to get old with CF? And they gave me 2 books about it. One was called Alex, The Life of a Child, and the other was Give Me One Wish. And both of these told stories of children and young adults dying with CF. And she says, you know, me and my parents, we didn't talk about the books. I just read them on my own and was like, oh, so that's what it's going to look like. So my parents, they were very information kind of people. They were intellectual. They really expected me to learn about it. So she was kind of sitting alone with these stories, but without anyone to really talk about these things with as a 9-year-old. Anthony also came from a family where there wasn't a whole lot of discussion of CF, although his parents provided really good care to him. And he remembers being in the hospital. I think they thought I was playing with the other kids, and I was purposely trying to eavesdrop because I knew they were talking about me. I just remember like it was yesterday, being in that room, playing with my friend Eric, who's no longer with us. And at 13, 14, you hear your doctor telling your mom, like you have a couple years left. And it's devastating what it does to you mentally, or what it did to me mentally, I believe. This contrasted a little bit with Rachel, whose family really talked a lot about CF. They talked a lot about like justification for different treatments. It was very much a part of what the family spent a decent amount of time educating her on. But she too remembers getting onto the internet at 12 or 14, right, a different generation. And she says, I would look up the CF Foundation. That's what I would read. That's where I think I found out about where I was reading about the life expectancy and stuff. But then at the same time, she had a grandmother who was diagnosed as an adult with CF, who's doing well and is in her mid-70s. So I was like, okay, I probably have some of her good. She's got something good there. Hopefully I inherited it. So I was negotiating with the data in my head. So you can see people get prognostic messages from so many different sources and right, CF friends and families. So it's not uncommon to be getting either really reassuring or really scary negative messages about the life experience of other family members or just, you know, friends in the community who are doing well or who've had a more rough time with CF. But it's an active negotiation, right? How do these things fit together? What do they mean for me in the future? Joe, who came from a pretty rough family situation with parents who were really pretty openly grappling and sharing a lot about how hard it was for them to have a kid with a diagnosis like this, says that in terms of the long-term implications, a lot of it was tied to, I guess, the average lifespan. That was probably one of the biggest things that's flagged in my head at the time. And that's what stuck with me the most. It doesn't quite define the way that I go about things, but I do take that heavily into consideration when trying to plan for the long term, because you can't quite, you know, invest in a 401k if you think about it. So Joe, who's again doing really well in his 20s on modulators, high FEV1, is still thinking a lot about this median lifespan that he had learned as a child or adolescent, and it's kind of impacting his decisions. So prognostic messages come from so many different sources, right? I've emphasized these parental conversations, overhearing doctors or talking to doctors, reading things, especially online, family members, comments from just sort of lots of different people, teachers, non-CF peers, and then of course, the physical experience, right? Which can be reassuring, I'm doing well, I feel like I can run really far, or really scary things like hemoptysis that can kind of make people think through what may happen to them. And importantly, these messages that people get about the prognosis can actually impact how they envision their futures, their prognostic imagination, which I use to describe the visualized projections that an individual can see, hope, fear, but also plan for their lives. And so I really want to emphasize that prognostic messages, really regardless of their accuracy, can impact behaviors, plans, and decisions. So Ellen described this, how when she was growing up, I was sort of catching up with the life expectancy, which isn't actually a thing, but kind of felt like a thing. So I was like, okay, I'll try to go to college, then I'll go home and live with my parents and die. It always felt like I was just leading up to dying. And she says, and one of the things I thought a lot about was my whole childhood had been everyone telling me, carpe diem, get excited, seize the day. And it was exhausting. It was exhausting to try to seize the day all the time. So, right, there's often that idea if you have a really serious condition that you should make the most of the time you have. But CF was at that time sufficiently survivable that by the third decade of trying to seize the day, she felt like she was really tired and just kind of like wanted to, watch TV and have kind of a routine sort of a life and existence. Anthony, who had overheard that he may die young, said, it's devastating what it does to you mentally, or what it did to me mentally, I believe. I spent the rest of my life trying to prove to everybody else that I was normal, and I can do everything that a normal person could do. And I regret that I ever had that mindset, because with relationships, I hid things. With employers, I hid things. I remember working. I did 20 years in banking, and I remember being in the employer's bathroom, coughing up hemoptysis. And I thought to myself, I should be in the ER now. How much? I mean, it looked like a murder scene. So having these physical experiences where you need help, clearly, but feeling as though CF was such a horrible thing from so early on that he had to kind of pretend to be normal. There was no interim message of like, if you take care of yourself, you can do okay. And consequently, he spent so much of his life pushing against this really scary thing that he'd overheard, but they'd actually never had a conversation about. And so it impacted his decisions. Rachel describes how she was negotiating that data, right? Healthy grandma in her 70s, CFF website, median life expectancy. And she says, I used that information, I think it was mainly that year that she had been really sick, and especially getting married, was a catalyst to a lot of these conversations about the long-term course of CF. Because it was like, okay, this was the person I wanted to spend the rest of my life with. Okay, what does the rest of my life look like? And that's what really started me thinking about what the future would be. So you can see how these big life events can also be read in a sort of more sobering way of, what does CF mean for the long term? Whether that's having children or getting married, it can prompt that consideration. For Joe, so much of the prognosis was sort of how we thought about money and finances and planning. So he went on at length, and you can maybe hear the anxiety in his voice about how the 401k kind of automatically put money aside for him in his first job. And he says, or, you start planning about, okay, I want to get a house with a mortgage. Well, mortgages have a standard 30-year loan. You know what I mean? So it's like everything has a lot more weight to the way that you go about things. So I start looking into alternative ways of saving money that still provides high yields, but also allows you to access the money at an earlier time. So, Roth IRA style and stuff like that. But it's like a lot of that stuff you shouldn't have to worry about at the age that you are. So it tends to alter the way I perceive things. And in turn, I feel as though it's made me more disconnected with some of my peers who are my age. So for Joe, it's kind of twofold. The prognostic ideas about CF, and again, he's doing pretty well, but are making him manage his money differently and think about every kind of financial decision quite differently, and as if it's so much more weighted, because he said, 30 years, what's my help going to be then on a mortgage? But it's also alienating him from his peers, right? Because they're not thinking about this in their 20s, so it's sort of twofold. So prognostic messages can impact plans, behaviors, emotional health, how benchmarks like marriage are experienced, how people set goals or decide to use their time, right? That pressure to carpe diem. And also psychosocial adaptation from kind of goal-oriented behavior to sort of a fatalistic sense of what's going to come next. I've certainly talked to a number of people with CF who at some point in their 20s decided to just party really hard because that's what you do if you don't have a lot of time. And oftentimes that wasn't good for health, right? And then, of course, all of these prognostic expectations are further evolving because of modulators. And we're increasingly seeing coverage in different publications about sort of what it's like to live longer than you're expecting to. And this was certainly the case for some of the people that I have interviewed. So Ellen, again, who is in her 50s, describes how when she first got married, she and her partner were hoping they could just have 5 years together. And now they're almost at 26 years. And she also says how growing up, her mom would always say, your head hurts, oh, that's because of CF, everything's come because of CF. And now she is kind of entering her 50s, and she says, you know, that things will be hurting, and it's not always CF. And now it's like, that's not CF. That's actually just being 51. It's actually kind of fascinating. So whereas Joe is like feeling really out of sync with his peers, Ellen was like, it's great. All of a sudden my friends are talking about health too. Like all we do is complain about our bodies. This was never my experience growing up, but I finally kind of like fit in, and it's not all CF. And she could kind of envision actually getting older and having a very long marriage with her partner. Anthony talked to me about the fact that he was stabilized on modulators, but at a much more advanced point in his disease. His FEV1 is in the 50s, but he also had a lot of other medical problems that he attributed to CF. And he says, you know, Becca, I still don't think about the future because CF likes to promote other illnesses in the body. I got chronic kidney disease from decades of antibiotics. I got heart failure from bronchodilators. I got diabetes from the prednisone that I need to take for CF. So having CF is no longer my number one concern. Any one of my organs can say, you know what, I quit. I'm not doing this no more. So I don't think about the future one bit. So there are people, right, who are stabilized on modulators to an extent, but at this very advanced stage where everything is still very tenuous and where that period of living with a somewhat advanced disease and multi-organ dysfunction is actually really just sort of indefinitely extended, but in a way that doesn't, you know, recast the future as any more sort of taken for granted. For Rachel, who started modulators as a young woman and was really doing quite well with a big bump in lung function back into the 90s, describes how when modulators came out, that changed everything for me. So that restored a lot of my hope. And then at that point, I think I was married a year before the modulator came out. Originally, I was like, there's no way I'm healthy enough to be pregnant. But with the modulators, that kind of increased the hope that I had. And we ended up having 2 kids. I had never thought I would need or want to save for retirement because I was like, what's the point? Let's travel now. But my husband and I will actually probably be able to retire together. And so for Rachel, right, these big things, having kids, planning for the long term financially rather than making the most of each day, were really different because of modulators. And I'll also share that Rachel actually ended up having a CF pregnancy. So she really had to rethink the prognosis in so many different ways to make her own reproductive decisions, if we want to touch on that in Q&A. For Joe, who had really held on to the life expectancy that he read as a child, and really had no one to talk to about it and was really quite fearful. He says, you know, with the modulator, it's not as bad now, right? I don't think about it as much. But the way I used to express it to people, which is kind of morbid, but if you imagine a bomb strapped to your chest with a timer on it, and the time's getting pretty low. And then every once in a while, somebody just walks up and kind of adds a few more years to it. That's kind of the existential feeling. Yeah. So modulators added some time. He felt less cognizant of the prognosis day by day and a little more hopeful, but he still sort of felt like anything else that comes out, that's for the young kids. He's telling me in his early 20s, right? That he's not going to really see a lot of benefits, and it's still quite dire. And he still feels a real limited sense of time, so much so that, right, he wants that Roth IRA account so that when he's disabled in his 40s and 50s, he can pull from it. And he's still really imagining his life to be very different because of the CF. So modulators, and we see this in the literature, right, they can shift conceptions of the future. There can be a new sense of possibilities, a need to plan for a future that may not have been anticipated, which can bring sort of some stress and anxiety with it. And then for some people, there's stabilized health, but no major shift to expectations, right? Because many people are stabilized with pretty advanced disease. And I wanted for this group to emphasize what people have shared with me about what was helpful, in so much as they communicated with people about the long-term course of CF and disease trajectory. So Ellen shared that in the course of her CF care, she had switched from one adult clinic to another. And she says that it felt like those folks, the previous folks, had been working their hardest to keep me alive until I died. And at the new clinic, they were working hard to keep me alive until there was a cure. And there is a huge difference in the sensations of having doctors who are not hopeful and having doctors who are like, something will happen, something will improve. And not hope in a Pollyannish way. Just like, look, there's a lot of research. We don't know. And so that really impacted my life because it really opened up a sense of, hey, there's a reason you're exercising. You're exercising because you need to be here when they figure things out. And so that really helped. So for her, hearing that like, they didn't know how long she was going to live. The doctor said that directly. We don't know. You know, you could live for a long time. And that the better she was doing, the more that she was adhering to the different treatments, the more likely she would benefit from what came next was really palpably different for her and really motivating in terms of her care plan. For Rachel, again, who was in her 20s and had never really had a super advanced disease, but she'd experienced a decrease in her lung function in her teens. And she says, I think having a face-to-face conversation with a clinician would have been helpful to just be like, even just to be reminded when I was feeling so low, I think I could have used a little more infusion of hope to be like, you're still at 80%. That's still great. To me, it was like, this is the end of the world because I've been in the triple digits for 20 years. And I think just that would have been helpful to be like, okay, these are the things. We still have more up our sleeve. Like, you're not in terrible shape and we still have more we can do. That would have been really valuable because she had no context for understanding what 80 versus 100 lung function was. For Anthony, whose disease had really progressed, who was like pushing really hard in his work life until he got very, very sick, he says that the doctor who confronted him about that is probably the reason why I'm still alive, to be honest with you, because she shook me up. And it was the day before I went home. And she goes, look, you just stay on this regimen or you're going to be on the transplant list. And the other part of this conversation she had with me was I had to take time for myself. She said, you have to do you. You have to protect yourself. You can't always be doing everybody else. You can't worry about work, right? So people really appreciated those, what I would call like reckoning conversations, where doctors were tough and hard about what was happening and what needed to happen in order to stabilize health. And for Anthony, he was able to make some major changes and again, like stabilize at that period, go on disability and really change how he was living in order to, you know, buy himself time and stability through changing his regimen. Joe was one of those people who dealt with everything internally, and he wasn't very hopeful about sort of what clinics could do to help him. But he did say that in the grand scheme of things, having a therapist outside of the clinic, and then an accountant, like somebody who really knows their stuff, who knows the best way to operate around on those things, because there's no way they haven't dealt with a scenario where somebody is in this position, not necessarily with CF, but where they can't invest in the normal way. So find somebody who knows their stuff about money so I don't have to learn it on my own, right? Joe felt really isolated, and just having someone who could kind of help him think rationally and with knowledge about the real financial anxieties that he had would have been helpful to him, along with like a therapist who maybe wasn't connected to the team and could just help him more generally. So what does this all mean for our practice as genetic counselors and for the CF care team? Obviously, we spend a lot of time educating patients, but I think it's just as important that we assess people's perspectives, ask and probe prognostic expectations. People gather ideas about what's going to happen to them from such different sources, and they can be really potent. And some of it's like logical and truly what someone expects, and some of it is like, I mean, this one man shared with me like an image from a video game that he just associated with like dying from CF, and it was potent and on his mind in a way that was actually very unlikely given his clinical trajectory to date. And so getting a sense of what people are carrying with them in terms of prognostic expectations can be really important. That can also be an opportunity to identify misperceptions. Assessing informational needs, right? How can we help people understand disease trajectory better? And then for some people, what you can hear in their stories is isolation. So querying specific connections or supports that might be needed. Right? We spend a lot of time providing information, but I think we always have to lead with like what a spectrum CF is, right? As genetic counselors, I'm sure you do this. And then providing anticipatory guidance about the fallacy of median life expectancy. I hope we don't use it clinically because it's really not helpful, but it's out there, right? So we have to provide guidance about like why we even keep track of it. And I would say in CF, we keep track of it because it gets better and because it shows how much progress we've made, not because the number at any point in time has any value for any individual patient. And then, of course, clarifying what genotype can and cannot predict, along with that spectrum conversation, right? There's only so much you can know, and I think it's easy to read more into genotype than is justified. I certainly heard that from some of the people I spoke with. And then, as you can hear with Ellen's story, right? Getting a sense of like motivating treatment, what's gonna get someone to really care is important. And one of the individuals who was kind of like not into modulators at first described how it actually took the respiratory technician saying, here's some science, like this is what we're seeing in the trials. And oh, by the way, 2 of my patients are now running marathons on modulators, was actually really important for him thinking, okay, I'll make the time for that pill. Like I take 1,000,000 pills, but I'll take that one because you've given me really good information and also stories that then motivated his decisions. As is so often the case with communication, people really value transparency. So willingness to hear about a patient's approach to adherence, even if it's not exactly what clinicians would like. Speaking really frankly when decline is happening, and talking about it, factually. Like, so for Rachel, hearing that you're in the 80s, and yes, that's not the 90s and the 100s, but this is what it means, and this is what we can do. Or for Anthony, hearing about the fact that like he was really kind of about to fall off a cliff with his lung function and that he had to change, and being really clear and firm and transparent about that was critical. And then, of course, these are really hard conversations, so focusing on anything that can be done to support stabilization was really critical for patients, the people I spoke with, not just sort of burying themselves with the information, but thinking, what can I do? And finding hope within that. So, right, considering how we convey hope just in our own way of being, in what we decide to share with families and with patients. For Ellen and a few others, it was shared with me that comparing a patient to their baseline versus to like, oh, well, other patients are doing much worse than you. That was the way to sort of convey like, this is inevitably going to be bad. Whereas saying, you're not where you were last year. What could we be doing different? Was really a way to compare hopefulness that someone could be stable over time. And of course, people get hope from really different sources. So trying to get a sense of that in your provision of care. And then when it comes to connecting patients with different types of support, there's so much more now than there has been in the past. And so this is just a list. I'm happy to speak to any of these, but there's a lot of resources for families and also for adults that are really fantastic. I spend entire weekends with friends on Zoom through retreats in the CF community. And there's a lot of good asynchronous sources as well. So with that, I just want to thank all of my different mentors, and I'll also thank the Penn CF Center for letting me recruit through them, and I'm happy to answer any questions. And we could probably do questions for everyone.
Thank you so much, Becca. That was great.
Hi, Karen Rary from Johns Hopkins. I'll bite on your offer. So the woman, Rachel maybe?
Yes.
Who had a CF pregnancy, how did that go?
Yeah, so Rachel, again, speaking for the needed genetic counseling, I don't know the details of her husband's report, but she was someone who had her first pregnancy and had reassuring carrier screening. Went through that pregnancy, child was unaffected. And then sometime during the second pregnancy, somebody else got hands on the report or sent to a different lab or a different panel, and she found out that, in the early part of the pregnancy, her husband was a failure. And she really, she didn't know the condition, but she really was trying to do the carrier screening and was really reassured initially and didn't want that child with CF. She's had a rough enough time with it that she was really hopeful that she wouldn't have kids with CF. I did get the sense that, she had religious beliefs that would have made that a really challenging decision. And she is the person who had a grandmother with CF, right? So she had a lot of different ideas about what CF could look like. And she shared with me that it really took a lot of time and conversations about prognosis to think about the fact that what she had lived through with CF would be potentially very, very different than what her son would potentially be living through. And so she had the conversation with modulators. She ended up staying on modulators during the pregnancy, which was incredibly helpful. We're both excited about that. I will share that she did have a very significant patient. So she had a pretty significant lung infection, but I didn't feel like it was my place to probe it immediately, but I really wonder a lot about conversations about prognosis for offspring when there's a multi-resistant infection, just because if you think about it, the age at which someone is colonized is like a big prognostic factor. And so I really wasn't sure and I couldn't assess and did wonder if that had also been part of the conversation. That like, yes, care is so reassuring, you're building on modulators from a young age, like, you know, the sky's the limit with new treatments, but that then would also be an exposure. And so I've always wondered, not just those cousin situations, but situations where parents are affected. You know, there's many women, as I'm sure you know, who get, you probably dealt with them, who get diagnosed like during a pregnancy, oops, they also have CF. So those conversations around cultural results and offspring got to be really challenging to navigate. And I have no experience with them, but they come up every once in a while in an interview where I encounter someone who's making all kinds of kind of conclusions about what their child's life will be like, and I know enough about.
Three really amazing talks today, so thank you so much. Beck, I'm wondering if you have any thoughts or plans to interview people with VVCCs or uncertain genotypes where the diagnostic odyssey is less than.
I don't, but I would love to. And I also think that adult diagnoses present really interesting questions with respect to prognosis. They're not a part of this study, but I've certainly encountered them. And have been really surprised by how people in that situation kind of make sense of the median life expectancy in particular, like whether it hits them or not. And I would love to spend more time with people who have more ambiguous diagnoses, and especially these adult diagnoses, because I think it just raises so many questions about what does it mean if you haven't come to, you know, medical attention until a certain age. So yeah.
Hi, I'm Jackie Spano from Stanford. I'm a nurse practitioner, not a genetic counselor. I spend my day either doing research or doing clinical, and I see so many families that have this baby, and we had counseling, we had testing, and how did this happen? Well, they've elected always to choose these panels that are limited and cost. So my question is based on cost. How much, as you as genetic counselors provide for the family, how much is covered under insurance? Because invariably when I further ask questions, these families elected to choose some limited panel because the next choice was thousands and thousands of dollars and not covered. So just could you speak a little bit on that?
So I think that this is one of the biggest myths in genetic counseling. The ideas out there are genetic testing, expensive. That is not the case with most carrier screens. Vast majority of carrier screening, depending on the size of the panel, is covered by insurance. If it's a big enough panel that's not covered by insurance, the labs often have a very reasonable out-of-pocket self-pay price. So the out-of-pocket self-pay price for even big panels, which include full gene testing, would be something like, and this is different depending on which lab, but $249, $349, something like that. So the emphasis is too often on costs. And this day and age, it's very unlikely that if you meet with the right provider with the right level of expertise that you would wind up having a multi-gene panel. You would usually have full gene testing.
I do also want to throw in some of, like, my experience. I'm not prenatal, but I do see people after the fact. A lot of these people get their carrier screening from OBs. They only meet with a genetic counselor if they have an abnormal result. So they might be getting misinformation from that avenue. So I think we as a community need to really start engaging our colleagues sort of across the side on the MFM or OB team too.
Just to comment about Becca's talk, thank you so much. It was amazing. And I feel like nobody has ever said to me, you gave me too much hope. I'm really mad at you. So like, I just feel like you cannot emphasize the value of hope. And while it's really important about what we say to our families, it's also important what we're not saying. So if you never address life expectancy, that is a problem. So usually even in the newborn diagnosis setting, I'll say to families, so, tell me a little bit about what you know so far about CF. The conversation will often come up about life expectancy. Then, usually what I'll say to them is something like, CF, in today's world, if we focus on life expectancy for cystic fibrosis, we are going to do a major disservice to ourselves and wind up spending a lot of time focusing on something that is not a current focus for cystic fibrosis. In today's world, with the advances in treatment, this is what we need to think about this as a chronic illness, something like juvenile diabetes, for example. So with a little bit of luck and a lot of daily care, kids and people with cystic fibrosis can do amazing and live a very high quality of life. Could they have certain illnesses and certain struggles? Absolutely. But what we're going to focus on is the normal with cystic fibrosis today. And that is not a continual worry about life expectancy.
Thanks. I'll just also share that I think that life expectancy is always historically so biased, right? Like it factors in people who have been living for a very long time. And so when you're dealing with the family of a young child, like it's important to say like, yeah, it's out there and it gets a lot of bandwidth, but really why we care is because it goes up so much over time. Like that's the whole reason we track it as a community. It shows, right, like where all the fundraising is going, that this condition has become so incredibly survivable, but the actual number is so historically biased by like a lot of older people that it's like off the table for a young person. And then I'll also share that like CFF has done interesting, public facing work with adjusted life expectancy, which still has its challenges, but there is nothing like being in a CF Facebook group and seeing someone share adjusted life expectancy. People with CF have such gallows humor, right? So it's like, 20 more years of this, but it really does show you. And I really was part of a group where people were just chatting about it. And it was just so interesting because the adults were like, guys, what this shows you is like, make it through your teens. Like, don't mess up as a teenager. And then like, you can see how you really have a lot of time ahead of you as you survive through different decades. And so there's also kind of like, for people that are really grappling with it, like the people I've spoken with, I think some of that educational work might have value if the number's already weighing on them for decades to say like, let's unpack this, let's unpack it from a statistical perspective that, might help, and certainly did in this group that I was in.
Okay, well, I think we are at time, and thank you all of you for listening and to our presenters for their wonderful talks. I do want to give a shout out to members of the CF SIG, the NSGC SIG. There will be a meeting on Friday at 1 p.m. I believe it's between the two poster sessions. And we're meeting near the GC Focus posters. So that'll be 3:29 to 3:33. Hope to see you all there.
Thank you.